The tensor fasciae latae starts from the ACES, anterior superior iliac spine, going on the iliotibial tract and enter the Gerdi tubercle near the tibia. So this is the beginning where it starts, and then we see the iliotibial tract and all the way down to the tibia next to the Gerdi tubercle. We ask our patient to make a contraction. So first we ask to push with the knee towards the inside, and we see the bundles here under my left finger. This internal rotation is very useful because it makes us see the bundles very clearly. I'm asking the patient to do it again. It's also sort of flexion, because the greater the contraction, the more the bundles come out. So once we locate it, we can do the palpation, always transversally compared to the bundles of the muscle, with the thumb or with the index. We can do this ischemic compression on the thought band or on the trigger points, and then here, as you can see with the thumbs. Once we feel that the muscles have relaxed, we can move on to another trigger point. Let's now see the same technique on the QL, and let's try to stretch it. Let's do just a little variation. Let's stretch it. Let's cross the legs, the iliac crest goes down, it gets farther away from the 12th rib, and then our QL will be stretched. In this position, we lean on top of the patient and we do this ischemic compression. It's a very sensitive spot, so we need to be cautious and pay attention to the reaction of the patient. When it's better to use this position or the other one. So the one with the crossed leg is better, and we use it when we are dealing with patients who are very contracted, and it seems like the iliac crest is right on top of the 12th rib. So it's almost impossible to touch it. So in this case, we prefer to cross the leg and stretch the QL, because otherwise it would be untouchable. This is just a hot tip. The patient is supine. Now we ask the patient to make a flexion, a very gentle flexion to locate the scum. As we saw before, the palpatory anatomy is quite visible. Then we use a pinch grip, and with the pinch grip we grab the scum. It has to be comfortable, it doesn't need to be painful, even if this technique is always a little bit annoying and unpleasant. When with the pinch grip, we have palpated the neck in order to find the trigger points and then the thought band. We will do the pinch grip to do this ischemic compression. Of course, we would have no possibility to push against anything hard. That's why we need to do this ischemic compression with the pinch grip. It is a quite long muscle, so we can decide where to work and where to palpate depending on where the thought band is. This ischemic compression can be held for several seconds, can be 30, 60, 90 seconds maximum. A reduction of the symptoms gives us a positive feedback of releasing a trigger point.
Now we will search for the trigger points of the upper fibers of the trapezius muscle. Once we find the thought band, three situations may arise. Local pain may be present, or pain may radiate from the same point either upwards or downwards. And small fasciculations might appear visibly while staying in the same spot. After identifying the trigger point, we apply digital pressure to create a situation of low blood flow, or rather hypovascularization, which creates a relative ischemia. We keep the pressure for about a minute and a half, or until we feel the thought band release under our thumb. At this stage, the pain perceived by the patient decreases, and if there is any eventual fasciculation, it tends to disappear as well. How do we engage the lower fibers? We request the patient to pull back both the shoulder and elbow so that a contraction is created that makes the entire margin of the trapezius stand out, as you can see, and thus also the lower part. At this point, we pinch the muscle in the lower branch and ask the patient to release the contraction to grasp the lower fibers of the trapezius this way, in this manner. Our objective is always to locate the taut band and discover, as we have seen before, the area of local or referred pain according to the patient, or we can find fasciculations as we have noted. At this stage, we perform the technique as we have seen before, maintaining this compression for approximately 90 seconds to deactivate the trigger point of the lower trapezius fibers. We can apply another technique. The one we just used is one, and this is another that involves accessing the deep fibers like this, which lets us find and address other trigger points as well. We can ask the patient to perform hip abduction, meaning to lift the leg. While resisting with one hand, we can palpate the contraction of the gluteus medius and minimus, because both of these muscles are abductors. At this stage, we ensure the patient is comfortable and use both fingers to locate the tense parts of these muscles. Once we find the tight area, which may correspond to the pain referred by the patient right at the moment of our palpation, we locate the tightest part that corresponds to the trigger point. Once we find the trigger point, as in this case, we ask the patient, is there radiation going down the leg? If the radiation is typical of the sciatica described by the patient, we can be fairly certain we have identified a trigger point for sciatica. We can choose to apply pressure on the trigger point in various ways, using our thumbs or fingers, and we maintain it for about 90 seconds or until we feel the muscle give under our fingers. After reducing the tension of the trigger point we found, we look for others, always in the gluteus medius and minimus group. The important thing is to stay in this area. The most represented trigger points of the piriformis muscle are located at the origin and insertion, meaning in the sacrum and on the greater trochanter. The patient must be in a comfortable position to ensure the affected muscle is relaxed. We identify and locate the trigger point with flat palpation using our thumb. We apply pressure gradually, steadily, and slowly to the trigger point until we detect the first palpable barrier. We maintain the pressure until we feel a softening of the trigger point. The wait can be seconds or minutes. We repeat the action, increasing pressure on the trigger point until we find a subsequent barrier, and so forth. After maintaining ischemic compression for about 30 seconds, it will feel almost like a slow progressive settling of the muscle, which causes the hand to sink slowly downward. At that point, we release and then increase the pressure on the trigger point until we find a successive barrier, and we repeat until we feel a density that is almost normal under our fingers. At that moment, we move to another trigger point and repeat the same treatment.
We place comfortably the arm of the patient and we go on the lateral side to locate the lateral epicondyle, where we know that we can find the extensors. Following a distal line, we can find the distal insertion of the long radial carpal extensor and the short radial carpal extensor. Now I'm showing you the brachioradial. It is a very easy muscle to locate, and by asking the patient to flex a bit the elbow in semi-prono supination, I can see it, and if I ask her instead to do an extension of the wrist, I can locate the long radial carpal extensor. Right under the long radial carpal extensor, we can find the short radial carpal extensor. Right after, we keep palpating transversely the muscle in order to find the taut bends and the trigger points. Now we are doing an ischemic compression in the long radial carpal extensor.
That's it for this Trigger Points Masterclass. I hope it helped you gain clarity and confidence in your manual therapy practice. Now, if you want to keep learning, click on the video thumbnails on the screen to explore more techniques and tutorials on manual therapy. Don't forget to like this video, share it with your colleagues, subscribe to the channel, and leave a comment below. Your feedback keeps us going and helps us create even better content. And before you go, check the link in the description to discover our complete video courses and take your skills to the next level. Thanks for watching and see you